Hello everyone, this is Cheyenne Harris. I'm going to do an overview of hypertension disorders of pregnancy for our virtual skills fair. So hypertensive disorders in pregnancy, there's gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and superimposed preeclampsia on chronic hypertension. So hypertension affects 6 to 8% of all pregnancies. 6% of all maternal deaths are related to hypertension. And then African American women are 3 times more likely to die from these disorders. Preeclampsia often affects nulliparous women, which means first pregnancy, they have not been pregnant before. Older women are more likely to have superimposed preeclampsia, and the risk of developing preeclampsia gets greater, almost doubles in patients over 40. Other risk factors are multifetal pregnancy, so your twins, your triplets, your quads, and more. Advanced maternal age, as I talked about. Obesity, of course. Chronic hypertension, of course. Diabetes, all of those things that go together. And then the very young maternal patient as well. So how do you tell the difference between chronic hypertension and preeclampsia? Chronic hypertension is primary or secondary. Preeclampsia is a multi-system disorder where hypertension is a symptom and not the primary disease. Hypertension experienced in preeclampsia is actually the body trying to compensate and maintain homeostasis during the presence of vasospasms. Gestational hypertension is another term that you will hear used. This is any new onset elevated blood pressure in pregnancy. This is diagnosed after the 20th week of pregnancy. So there's a big difference. If it was diagnosed before the 20th week of pregnancy or even pre-pregnancy, then it's considered chronic. And gestational hypertension does not have proteinuria. This is defined as a systolic of 140 or a diastolic of 90 on 2 occasions that are 6 hours apart. And these patients usually have a normal blood pressure within weeks of postpartum. Excuse me. Of course, we know chronic hypertension, again, an elevation of blood pressure 140/90, but this is when it occurs even before the patient was pregnant or before 20 weeks gestation, so that it's not attributable to the trophoblastic disease. Preeclampsia is specific to pregnancy and reduces organ perfusion from the vasospasms we spoke about and endothelial activation. So you have to have the 140 or 90 after 20 weeks, as well as protein in your urine. And proteinuria may be a late sign. It's not one of the telltale first signs in preeclampsia. When you get severe preeclampsia, you're looking at pressures of more like a systolic of greater than or equal to 110, diastolic greater than 160, diastolic greater than or equal to 110. A larger amount of protein in a 24-hour urine or on a dipstick. You start to see patients who have visual disturbances, frontal non-remitting headaches. They may have epigastric or right upper quadrant pain. Their babies will be less likely to grow, causing intrauterine growth restriction. Liver enzymes, your AST and ALT, will start to be elevated. Their urine output will decrease because their kidneys aren't perfusing. And then they can also have pulmonary edema and a shift in their blood count. Superimposed preeclampsia sounds very fancy, but this is just a new onset of proteinuria, qualifying you as preeclamptic, and people who were diagnosed with hypertension prior to 20 weeks. So those people who were already chronic, and then all of a sudden they add in the proteinuria, the severe hypertensive pressures, or they have a drop in their platelets of less than 100,000. So it is possible to be chronic hypertensive and then also develop preeclampsia. And we actually see that a lot. So possible etiologies. So there's an initial or abundant exposure to the chorionic villi. These patients may have pre-existing vascular diseases, and a lot of times that's the case. Genetic predisposition. If your first-degree relative was preeclamptic, you're likely to be preeclamptic as compared to the person who doesn't have a first-degree relative, like their mom or sister. There is a diminished blood flow leading to ischemia and necrosis and hemorrhage in the organs. And it's also thought to be an immune system response to a foreign substance like your fetus or your placenta. Other interesting observations of women with preeclampsia, like I said, first-degree relatives. There are also fathers, those baby daddies whose previous partner had preeclampsia, will have an increased risk with their subsequent partners in the development of preeclampsia. So if his last woman had preeclampsia and now he's having a baby with you, you could also possibly have preeclampsia. And then people who have fewer sexual encounters in their life or have used condoms as a method of birth control regularly are more likely to develop preeclampsia than women who did not use condoms regularly or had more sexual exposures. And they think that this goes along with the reaction of your body to foreign substances. The more that you're desensitized, the less likely your body is to react. So this would be about the only time that you hear healthcare officials say that it actually did them well to not use condoms and have sex with many people. The assessment of a preeclamptic person or a patient who's pregnant with hypertension, you want to look for those headaches. Most of the time they're going to be frontal and non-remitting. Visual disturbances, that could be anywhere from seeing different colors to seeing spots or seeing floaters. Epigastric pain with severe nausea or vomiting, almost like when you would think that your patient is having a gallbladder type situation. Sudden weight gain and increased edema. These patients third space all over their body. You want to look at blood pressures, of course. You want to look at their deep tendon reflexes to see where they're at in their seizure threshold. Of course, check urine for proteinuria, look at edema, and then do a lab evaluation of all of those listed below. So I'm not going to go a lot into the labs because most of us know how the labs work, but you're more than welcome to read these. Looking at platelets, of course, if that drops, then that's indicative. You want to look at fibrinogen because of the anticoagulation status, especially with the platelets dropping. A CMP because it also adds in the kidney and liver and electrolyte balance. So treating these patients, there really is no treatment for preeclampsia. There is treatment for the hypertension. So our number one biggest goal is to prevent stroke. Like I said, it is not uncommon for maternal death to be related to cardiovascular disease. And it's the stroke that will kill you, the seizure won't. So we want to prevent stroke. Of course, we want to forestall convulsions if we can, and prevent intracranial damage and damage to other organs, and of course, deliver a healthy baby to a healthy and alive mother. Things that you may do for this patient is have them on bed rest, depending on the severity of their disease, control their hypertension with meds. This is done prenatally as well as intranatally when these, and postnatally as well, when these patients present in hospital, and we'll see our severe hypertensive protocol for that. Fetal surveillance, so we can see how their baby's doing and if their baby's struggling in respect to the changes going on in her body. Seizure prevention, and then lab monitoring. So of course, seizure prophylactics, we want to keep the environment quiet. We want to maximize perfusion, left lie, of these patients and give magnesium sulfate in the severe cases. So MAG works by slowing neuromuscular conduction and increasing the seizure threshold that we often see decrease with preeclamptic patients. It does have a transient effect on blood pressure, but it is not used as a blood pressure treatment. Keep that in mind. It is given IV. It can be given IM. We do a loading dose of 4 to 6 grams over 15 to 30 minutes. This should be administered with a separate piggyback. You should never administer the loading dose from a maintenance bag. 2 nurses should verify the pump settings, and the nurse should remain at the bedside during the infusion of the loading dose. The maintenance dose is usually 1 to 3 grams an hour, depending on what the provider wants. And they'll usually want to keep total fluid intake at 125, may even be less than that, depending on the provider's preference. So again, piggyback this into a mainline fluid. We usually use LR. This is never administered mainline. And there's just some more information there on magnesium sulfate. You want to make sure that during your loading dose, you are assessing the bullet point where there's INO, DTRs, level of consciousness, respirations. During the loading, that's every 5 minutes. And then once you get to the maintenance dose, those are hourly. You want strict INOs. I often recommend putting a urimeter on, especially if their urine output is low. Therapeutic levels of MAG are considered to be between 4 and 8, and greater than 9 is toxic. So you want to really make sure that you're watching the loss of DTRs with these patients. And a lot of times for our magnesium inductions, if they get an epidural, you can't assess DTRs in the lower extremities. So you need to start assessing their DTRs in their upper extremities, because their lower extremities should not have DTRs if they have an epidural, or a spinal for that matter. The reversal of toxicity is calcium gluconate. If you don't know where that's located, it's in the L&D ORs in a green and yellow box. So now looking at antihypertensive medications, these are administered to our moms when diastolic is greater than or equal to 110, or systolic greater than or equal to 160. It does not have to be both. It can be one single being elevated. These are given, of course, to prevent stroke, because our moms, despite the fact that they may look like healthy young women, are capable of stroking and capable of dying from that, and very easily. And it happens, especially in America. So the goal is to keep it below those numbers. Maybe not for some patients to return to a normal blood pressure, or what we consider as good, because this can cause hypoperfusion, and the baby on the inside has been used to a higher pressure, but we don't want her at stroke level. So our number one go-to treatment is labetalol. It's safe for pregnant women. If you have a blood pressure of 160 or greater, or 110 or greater, and then you repeat it in 15 minutes. That's crucial. It has to be a 15-minute repeat. If that second one is elevated, then you start the labetalol protocol. You do not have to ask your provider to do this. It is a standing order and a standing protocol. You give 20 milligrams, IV push, of course, slowly. Recheck that blood pressure in 10 to 15 minutes. If it's still elevated, you go to 40 milligrams of labetalol. Recheck in 10 to 15 minutes. If it's still elevated, you're to give 80 milligrams of labetalol. So on a crazy day, this seems hectic. However, you have 1 hour to treat from the first high blood pressure. So don't feel that you have to treat it ASAP. It's best if you can, but I know that realistically in our line of work, babies come and emergencies happen. So just try to get that in at least within 30 minutes, but you have 60 minutes to give that. And then if the 80 milligram repeat at 15 minutes is still elevated, that's when you're going to go to hydrolysis. And if the blood pressure remains elevated after that, we want to, of course, notify our provider that we've gone through the whole labetalol protocol and we're still hypertensive. And we may look into consulting an intensivist or cardiology. Important things to consider when giving labetalol is it's a beta blocker. So this is not used for patients with asthma or heart failure. It could exacerbate those. Do not exceed 80 in a single IV dose. If the patient has a long-standing history of heart problems, you may look into EKG monitoring for these patients while you're giving these medicines. And bradycardia for the mother and the fetus is a common side effect when giving labetalol. Hydralazine, it can also be used as a first line if labetalol is contraindicated. So the first dose is 10 milligrams. You want to repeat your blood pressure, of course, and then you can give another 10 milligrams and consult with your provider because hydralazine usually should knock it out. However, we know that some of our pregnant patients still keep trucking on with 200s over 100. Things to consider when giving hydralazine is that hypertension decreases placental perfusion. So if you do treat these blood pressures, keep on the watch for baby to be like, what the heck are you doing? I don't like low blood pressures. It can cause tachycardia and it can cause a headache, which is, as well as labetalol, which is kind of a catch-22 when you're looking at a preeclamptic headache and you're assessing for the headache and the severity of it. However, we're also giving blood pressure medications that can precipitate a headache. So procardia. So this is recently added as first-line hypertensive, especially if you're attempting IV access. So if you have that patient who is really preeclamptic and you can't get a line because you stick her and her veins are floating in the massive amounts of fluid that she's retained, you're waiting on anesthesia to come do a line for you, and you have those triggering pressures. This is also a standing order and you can give it. So this is given PO. The first dose is 10 milligrams orally. Then you repeat a blood pressure in 20 minutes, giving it a little bit longer because it is an oral dose. Then if the threshold's exceeded, you can move on to 20 milligrams PO, repeat the blood pressure in 20 minutes. If it's still exceeded, you can give another 20. Then after that amount of time, surely you should have your IV access and you can go to labetalol or hydralazine if you can't give labetalol to that patient. And you do want to consider consulting cardiology or an intensivist as well when you're giving all these medications, especially if they're not being effective. So eclampsia. So we can go from preeclamptic to eclamptic really quick. And sometimes we miss knowing that they're preeclamptic and they come in seizing. So you become eclamptic when you are having tonic-clonic seizures or in a coma. And this can be diagnosed or undiagnosed preeclampsia, honestly, if we haven't caught the preeclampsia yet. It's sudden. The seizures are self-limiting. You should rule out other causes, and this can occur antepartum, intrapartum, or postpartum, honestly. So this could be a patient who's gone home after having her baby 5 weeks out can come in seizing, and it's not related to a seizure disorder. It's related to her pregnancy. So most common seen in the last trimester. So usually the face will start twitching, then the entire body becomes rigid, their jaw will open and close violently. Sometimes they make shrill noises, and then gradually the movements become smaller and less frequent. There are no respirations because the diaphragm is fixed. Breathing resumes, and usually it's slow, and then she becomes tachypnic. They may have the post-ictal combativeness, confusion, and we should treat this because it's more likely to continue to happen and can lead into status epilepticus. The best treatment for preeclamptic seizures is a MAG IV push of 4 to 6 grams, or running in a piggyback if you don't have access to the MAG IV push. You can give Valium to these patients, and it will help. However, the best treatment for a preeclamptic seizure is the magnesium. Of course, you want to get an airway when you can. Put these patients on their side, pad the side rails. You do not need to worry about monitoring the baby during the seizure because it's not going to look good. Have suction and oxygen readily available. Go ahead and put 10 liters non-rebreather up to her face, but do not put the straps around her head, because if she vomits and the mask is strapped to her head, she could then aspirate the vomit that's caught in that mask. So this just reiterates everything I've just said. If seizure activity recurs and you've given the 4 to 6 gram bolus or push, you can continue with 2 gram pushes or boluses over 3 to 5 minutes. And then maybe even have to consider intubation and mechanical ventilation if this patient does not stop seizing. So of course, after the seizure, oxygen, suction, blood pressure, pulse, respirations every 5 minutes until stable. And then you want to document all of the characteristics surrounding the seizure before, during, and after. HELP syndrome. So another scary thing that can happen to our pregnant women. So this is thrombocytopenia accompanied by elevated liver enzymes in women with preeclampsia or eclampsia. So hemolysis, elevated liver enzymes, low platelets is what spells HELP. Complications to this disease is placental abruption, which is the separation of the placenta causing large amounts of blood loss. Intrauterine growth restriction, intrauterine fetal demise, unfortunately. Pulmonary edema, of course, proteinuria leading to decreased renal blood flow and output. Vasospasms can cause hemorrhage in the liver, rupture and necrosis of some vital veins and organs, visual disturbances, retinal detachment, and usually a temporary blindness. And then if you do have the seizures, hypoxia, and cerebral hemorrhage or death, this would indicate that there's neurological involvement as well. So as a nurse, prompt recognition and interventions in a hypertensive crisis is vital. This is why we've had such a huge push for the hypertension protocol. And as Texas AIM continues to roll it out for the next year and a half, we will continue to see that and continue to improve our work in preventing and treating maternal hypertension. And of course, this is scary for the family as well, and something that we want to make sure that we're doing as we're doing our job is that we're reassuring the family and educating them on what's going on. All right, if you have any questions, please let me know, and thank you for watching.